Okay, welcome everyone to a subspecialty VMR. Today is a very special subspecialty VMR, one because it's a clinical reasoning VMR, and also because we have two really phenomenal guests. So I'm going to go ahead and introduce them before we jump into the case. So our first specialist discussant is Dr. Tony Breu. I don't think Dr. Tony Breu needs an introduction, but I'm still going to kind of summarize some of what he does. So Dr. Breu, or Tony, he's a hospitalist at the VA in Boston. He's also faculty at Harvard Medical School within the bioethics department. And he's also the co-host of the Curious Clinicians podcast. So Tony, welcome. We are so happy that you are here. Last time you were on, you did share a little bit about the origins of the Curious Clinicians podcast, but for those who weren't able to tune in, I would love for you to share maybe a little bit about yourself, a little bit about kind of the origins of the Curious Clinicians podcast, and then something I'm a little bit curious about is how has working on this podcast impacted your teaching, your clinical care? I would love to hear about that.
Yeah, so as Maddie said, I'm a hospitalist, full-time inpatient doctor at a VA in Boston, and absolutely love my job. It's the perfect job, and I think Justin Peterson is on here too. Justin, I worked with, he got to experience a full year of working at the VA. It's really a great place to be. For the Curious Clinicians, what I'll say is we started it because Avi Cooper, Hannah Abrams, and I felt like there was a lot more to say beyond what can be said in 280 characters, even if you expand 280 characters for like 15 or 16 tweets. And so we've really looked at it as an opportunity to sort of say more or just do it in a different way, in more of a conversational way, which, when you're writing a tutorial, it's not conversation, at least when you initially post it. Obviously, you hope for a little bit of conversation after the fact. And I'll be honest, one of the most important things I've learned through this process is, even if you spend hours and hours and hours learning something, as I often do when I'm writing a tutorial, you forget most of it. And the solidification that comes with putting together a podcast episode on the same topic, particularly if it's months removed, it is, again, a reminder of the deep loss of memory that you have after you learn something, but the profound value of relearning it a second time. So if anyone has read the book Make It Stick, this will sound familiar, but this idea of spaced learning really is valuable. And so as a plug, I'll say for the spaced learning series that the clinical problem solvers do, it's really an asset to solidifying what we do here.
Yeah, I love that. Thank you for sharing. I think everyone on this call who's at different levels of training in medicine can definitely relate to, you learn something, totally forget it, comes back maybe easier a second time.
Well, I just have to recognize Olivia Rouse is here too, and I haven't seen Olivia in months, and I miss her dreadfully. So hello, Olivia, as well.
Awesome. And just want to shout out, I see Charmine is here, and she's very involved with the space learning series. So just want to shout that out. Awesome. So thank you for answering all those questions. Actually, Sammy had a quick question, maybe before we jump to Margaret's introduction. How long does it take you to read and prepare for a podcast episode?
So the podcast episode typically takes a few hours. It's because Avi and I and Hannah and I specifically choose things that we've previously read deeply about. So in preparation for a tutorial, I probably spend on the order of 10, 15 hours reading, and then can sort of, as I'm relearning something, and it only ends up taking an hour or two to do. But it is a lot of work. Again, 10 plus hours depending on the topic. Hopefully it shows.
It 100% does, definitely. Awesome. So the other specialist we have discussing this is Dr. Margaret Lie. So Dr. Margaret Lie, she's a second-year internal medicine resident at Beth Israel Medical Center in Boston. Margaret, we're so excited and happy that you're here. Thank you for being here, and would love for you to share something about yourself outside of medicine. We'd love to get to know you more.
Thanks. I guess this is tangentially related to medicine. At BI, we have a track called the Digital Education Track, which is run by Dr. Shreya Trivedi, who's from Core IM. and Dr. Adam Rodman, who is part of Bedside Rounds. And so Tony came and actually talked to our group, and we're trying to each of us plan a podcast for Core IM. So that's been really challenging. Since we're also PGY2s, it's been hard to balance like doing digital education and going through our clinicals. So our timeline is very spread out, where we have like until February. So that's something totally new for me, and will be a good adventure. It's kind of like this discussion, since I don't know what the case is.
That's awesome. Yeah, I can imagine it's quite difficult to balance the digital education with your clinical responsibilities. So that must be a lot. But we're happy you're here. And then Vale will be presenting the case today. Vale, could you unmute and introduce yourself and also share something about yourself?
Yeah, thank you, Maddie. I'm really excited for this case. It's a human DX case though, and yeah, I'm going to be presenting. And well, I'm a 6th-year medical student from Peru. I just finished my OBGYN rotation, and well, outside of medicine, I really love to run, which I know is something that you and I have in common, Maddie. So yeah, let's get going.
Awesome. And then last but not least, I would love the people doing scribing and teaching points to introduce themselves, because these sessions can't happen without them. Sammy, do you want to unmute as well?
Hey, sure. Welcome, everyone. And I'm really hyped for today's session. I'm Sammy. I'm a last year medical student from Austria, from Graz. I'm currently doing clinical rotation in Michigan, and today was my first day. I'm quite exhausted after 12 hours, but that's the future, I guess. And yeah, I'm happy to be here, and I will be doing teaching points, and Shema will scribe today. Shema, can you unmute yourself and share something about you?
Hi, I'm Shema, and I'm a 50 medical student, and my German and Austrian friends already know that I don't sleep very early. Yeah, that's one habit that I have. Yeah.
That's an amazing fun fact. Awesome. Well, thanks everyone for introducing themselves. I'm excited to dive in. So Shema, you're the scribe. You can go ahead and share your screen, and Vale, jump in.
Can you make me co-host?
Yes, you should be co-host, but I will, oh, sorry about that. Make co-host. Okay, sorry about that. You should be all set.
Okay, perfect. So the chief concern is a 37-year-old man with fever and rash. Would you like me to elaborate a little bit more, or do you think it's a good stopping point?
Give us a little bit more information.
Okay, so this is a 37-year-old man with a recent diagnosis of HIV, who's had fever for the last 3 weeks, associated with anorexia, malaise, and 30-pound weight loss, and has had for the last 3 days a new rash on his trunk. And that's the first aliquot.
Fantastic. So I think Margaret was going to kick us off for the first aliquot, and I'll sort of fill in the gaps, and then we'll sort of go back and forth as we go. So Margaret, what do you got?
All right, I think there are a few really key points here in the fever and rash in a young man. So we've got first what fever is. I think on the CP solvers, you know that there's like the IMAID kind of mnemonic, where infection is always top of our differential, malignancy, autoimmune, any sort of drugs, or like endocrine. I think another thing that's important is thinking about the time course being 3 weeks long. So that also like infectious and malignancy come to mind, and maybe autoimmune and drug drop lower onto the list because of the time course that's gone on. And then last of all, talking about the specific patient population. So he specifically has HIV, so he's immunocompromised, which makes us widen or expand our differential into not just the typical sort of infectious bacterial categories, but things that are more prone to people who have lower CD4 counts, should that be this patient population. And then thinking about what does the rash look like? How long has this anorexia? Is this a confounding feature with his HIV, or is this related as well? So those are all like my disparate thoughts, but that's where I would start from.
Yeah, so everything that Margaret said is perfect. And I think starting with IMAID, even in a patient who has HIV disease, a new diagnosis is appropriate, because what you don't want to do is too quickly narrow on infections. And I'll just offer right up front that, as a reminder, everyone, things that can infiltrate the skin are certainly infections, but they also include things like B-cell lymphomas. And remember that HIV disease is a huge risk factor for B-cell lymphomas, or B-cell leukemia as well. So we cannot have a narrow differential, even though the infection in IMAID is going to be our primary focus here. And as I think Vishal put in the chat, a description of the rash is going to become paramount here, because if this is a typical erythematous morbilliform rash, then the probability that we might be dealing with something like a viral syndrome is high. But if it has a different kind of appearance with, say, Eschar's or sort of rather atypical rash, you might think about things like fungal infections like blasto. And then if it's not your usual rash and actually looks more nodular, you might think about things like erythema nodosum. And in patients with HIV disease, certainly that is an independent risk factor for tuberculosis, which can present with E. nodosum. So the rash appearance is going to be really, really important here, as is learning more about this patient's CD4 count, because as we all know, the degree of CD4 count depression is going to be an independent risk factor for all of these types of infections, knowing that some infections like tuberculosis are an increased risk independent of the CD4 count. So I think we need more information, particularly about CD4 count and particularly about the appearance of this rash.
And I also want to add on to what Dr. Breu said about how also location and travel history of this patient matters too. Coming here from Boston, we see a lot more like Lyme compared to where I was for medical school in Houston, Texas. So
it's a great point.
Amazing. Yeah, that was a phenomenal discussion, both of you, just with just a few sentences that we have here. I love how you touched on the time course, kind of started broad with the IMAID mnemonic, and then Tony, what you described, kind of how the specifics of the appearance of the rash kind of narrow your thinking. Similar to Margaret, your last point, I was curious, in addition to what the rash looks like, are there specific questions that you would ask a patient, with a fever and a rash, besides travel history, that would help you, that you would kind of really want to make sure you ask about in terms of history at this point?
So I'll offer a couple thoughts, and then Margaret, please fill in. So fever and rash can be a presenting syndrome for many, many drug eruptions. And so I would be particularly curious about newly started drugs, and I wouldn't just focus on the last few days, because many of these drug eruptions are delayed in their onset by a few weeks. And in a patient with a new diagnosis of HIV, it is quite possible that he's been initiated on new therapies. So drugs is one thing, for sure. And then I think a second thing I'll ask about, and then we'll see what Margaret has to offer, is vaccination status. Because again, you think about infections that can present with again, I'll use the word morbilliform, but a morbilliform rash and fever. Well, guess what? It's things like measles. And so understanding this patient's history of vaccinations will become important, because it will broaden the differential diagnosis.
I think for me, in a patient with a rash, always asking location and evolution of the rash, and where it started, how it started, how it's looked like when it started, and how it's come since then, can be really informative on diagnosis.
Yeah, fantastic points, both of you. Thank you. Okay, Vale, we would love some more information.
Yeah, okay, so I'm gonna give you some of the southwest corner and some of the physical exam as well. So his past medical history isn't remarkable. Only the new diagnosis a week ago of HIV at urgent care, and both antigen and antibodies were positive. He has never been on ART. His social history, well, he lives with his husband. He hasn't had any new partners in the last 5 years. He doesn't smoke, drink alcohol alcohol or any illicit drugs, and lives in the Midwestern United States and hasn't had any trouble in over 5 years. Okay,
No,
so yeah.
Nothing in the last 5 years, but any more remote travel that we're aware of?
I don't have that data, but it doesn't seem like it.
Perfect.
Okay, yeah, that's a good point. Like, you can have latent TB even if you are there like 20 years ago. So that's a great point. Okay, so we'll go into the physical exam. He has a temperature of 103.1 Fahrenheit, heart rate of 107, blood pressure of 138/84, saturating 96% on room air. On general appearance, he seems cachectic, ill-appearing. He also has some anterior cervical lymphadenopathy. There are no posterior lymphadenopathy, no erythema or exudates on examination of the throat. And then for cardiovascular exam, he seems tachycardic, but no murmurs. The pulmonary exam is normal. The abdomen exam is soft, non-tender, but it's remarkable for hepatosplenomegaly. The exam of the extremities, there's no lower extremity edema, and the skin, which is, I guess, the most interesting part, there's blanching macular rash on both an abdomen, back, and proximal extremities. And that's the description that I have. I'm sorry, it's a little not too detailed, but blanching macular rash.
Sounds like an internist. I love it. So Margaret, which of these chunks do you want to talk about, the past medical or the exam? And then I'll take the other chunk.
I guess I'll take part of the past medical history because it's so like simplified. Since he doesn't have any past medical history and hasn't been on any recent meds, it lowers our differential for the drug rash portion of it, where I think more infectious comes to mind, and then second of all, malignancy as well. I know you're going to touch on the physical exam, but I think it's really fascinating that there are, so I guess there's a lot of things to talk about, but not that many physical findings besides the lymphadenopathy, tachycardia, hepatosplenomegaly, and the rash. So like tying all those key parts together.
Great. So, you know, when we look at the exam, we see someone who has a confirmed fever, and you know, it's a high temperature, but the reality is I'm not going to make much hay of that, right? If this were a patient who was 80 or 90, I might start getting, you know, more alarmed at a high temperature and their ability to sort of appropriately respond physiologically to that. But in a young person, that's fine. In fact, my son had a temperature higher than this earlier today. He's doing well, don't worry. But the thing that's most interesting about this is the unexpected finding of cervical lymphadenopathy and then hepatosplenomegaly. And if we just had splenomegaly and cervical lymphadenopathy in a patient with a fever and a rash, I think we have a really good case for what's called a mono-like syndrome, right? So, you know, mono-like syndrome, particularly if we had pharyngitis, you want to think about in cases like this, fever, rash, and splenomegaly. And the differential includes not just EBV, but also CMV, HIV, acute HIV disease. So could this be just a manifestation of HIV disease? Absolutely. And also toxo. And so those are the sorts of 4 infections I consider as part of my mono-like syndrome. So again, EBV, CMV, HIV, and toxo. But he also has a hepatomegaly, and we trust Valley's exam, right? This guy's not just got splenomegaly, but hepatomegaly. And so what this now makes us wonder about is he infiltrating multiple spaces? So lymph in multiple lymphoid organs, right? The lymph nodes themselves, the spleen, and then the liver, and maybe it's the lymphoid tissue within the liver. And so once you get in that realm, I mean, obviously the differential includes things like infections and cancers, but we're also now expanding to these inflammatory conditions, many of them which have crossover with malignant conditions. So things like Castleman syndrome, particularly in a patient with HIV disease, right? HHV-8 associated Castleman disease. In this form, it would be multicentric Castleman because he would have hepatosplenomegaly. We have to begin thinking about things outside of the usual realm. And so if I were presented with a patient like this in front of me, I would really be interested in trying to ascertain the presence of lymph nodes that are enlarged outside of the cervical chain, axilla, epitrochlear, inguinal, to see is there more extension of this lymphadenopathy across just the cervical plane, which is pretty common for a viral infection. And if it does, it really is going to be opening up our differential dramatically. We can begin thinking again about these infiltrative processes. And we can talk more about infiltrative processes once we get some additional information and maybe confirmation of the fact that he has lymph nodes in other spaces. But just remember that infections can infiltrate lymph nodes, malignant cells can infiltrate lymph nodes. And then if you just look at the cells that our body makes, right? Eosinophils, mast cells, macrophages, typically in the form of granulomas, neutrophils, they all have their own infiltrating phenotype, and many of them infiltrate these lymphoid tissues. So this exam, is I would say fascinating that it suggests that we have organs, not just the skin, beyond not just the skin involved, and those include some of these lymphoid tissues. I'll be honest, the skin exam is, though it's interesting, I'm not sure it's yet informative to me. There are some syndromes that can present with an erythematous rash. I think Castleman's is one of those. And so again, maybe it increases the probability of something like that. And it's possible it's one of those things where if the progression of the rash over time may provide insights into whether or not it's actually a part of this, whatever this syndrome is. So here, I think, we've got a good exam. I would do a little bit more stalking of the lymph nodes. And then I think my guess is we're going to get some cross-sectional imaging here to see the extent of the lymph node involvement, or at least I would be interested in getting that at the very early stage. But I suspect we're going to be seeing some lab data first. So what are we missing, Maddie?
Yeah, no, I just wanted to comment. I think what really stood out to me is how you made that distinction. You laid out a differential for splenomegaly plus lymphadenopathy, the monolichen syndrome. What was really fascinating is your differential, changed significantly with the presence of hepatomegaly in addition to those. So that was a really helpful learning point to me. And the question I was going to ask that you did touch on at the end is kind of, does this rash help you prioritize the differentials you just mentioned for hepatosplenomegaly and lymphadenopathy? It sounds like, if I understood you correctly, it's doesn't allow you to make too much of a headway, but I just wanted to kind of clarify that.
It doesn't immediately help me, but that's probably a scenario where I have a knowledge gap, where if I generate my differential diagnosis, and it includes some of these infiltrative conditions, I would then look to see, is a rash a common part of it, right? So this comes up all the time, right? So you'll be presented a case and it's got a monoclonal gammopathy, and you'll forget that as part of the POEM syndrome, that S is skin findings. And we don't see POEMs very often. And it's actually quite remarkable how often skin changes are a part of systemic syndromes. But I can't keep in my head which do, and so I would be tapping into other resources. Now, I'm not sure you, Margaret, if you've got sort of any way that you would fold in the rash right now to sort of help prioritize your differential?
No, I think I would do the exact same as you, where I think for me, the hepatosplenomegaly and the lymphadenopathy are most interesting because I feel like the blanching macular rash could be anything. It's super non-specific. I don't think location or where it's from actually helps us that much. I would probably start from like the infectious or hematologic categories, going through like parasitic, like fungal, like histo, and like the CMV, EBV that you mentioned for viral as well. And then from there, looking to see like which one does they're looking up to see what rash matches the patient.
Now, what I really appreciate you both are doing is you're just being so, I think people say on VMR sometimes like authentic to the process. Like, I really appreciate how clear you're being about how you're using, you know, the knowledge that you have, but are open about what things you would look up and what things you need to kind of double check. So that's always very helpful for me to hear.
Yeah, and you know, the case like this where, you know, I see HIV, but I don't necessarily see untreated HIV as often, fortunately, by the way. And so the way that that presents is less comfortable for me than it is for clinicians who might be in their 60s or 70s, who saw a lot more HIV in the 1980s and early 1990s when we didn't have good therapies. And we still see it now, but just not nearly as frequently. Again, fortunately.
And I think I saw someone in the chat point out like smartly that it's really important to look at mucosal membranes and like do a really good exam of the entire body, not just the rashes, and like Dr. Breu said, also for lymphadenopathy too, because you never know.
That's a great point. And I see Shema mentioned a question in the chat that I would love to pose to both of you. So she's asking, you know, for Castleman's disease, do you guys know what time course we would expect for that disease to be evolving in HIV patients?
So I think this would be a slightly more aggressive form. Like I think someone noted that the idea of 30-pound weight loss in 3 weeks is just profound. And so this does seem to have an accelerated course for that, is at least as compared to the times that I've seen it. Is it within the realm of possibilities? Sure. You know, another condition that I think many of you are probably considering now that we have hepatosplenomegaly and a febrile illness is something like HLH, which undoubtedly can present in a much more rapid way. And so I think, you know, that condition is I usually see as a more acute, often acute on chronic. There's often an underlying chronic condition. And so I think keeping that in mind as well as we get more information. But for Castleman's itself, I would have to rely on others to help us out to know whether or not this is consistent with the usual presentation.
Great. Okay, Vale, give us more information.
Okay, perfect. So some initial labs, the CD4 count was 7 cells per microliter. His HIV viral load was 789,000 copies per milliliter. White blood cell counts were 2.1 with a hemoglobin of 8.8 and platelets of 77. Sodium was 128, potassium 3.6, a BUN of 18, a creatinine of 0.7, AST of 88, ALT of 91, alk-phos of 683, and total bilirubin of 1.2. And maybe I can give you some chest X-ray just to wrap it up with some nice imaging. His chest X-ray showed prominent periilear lymph nodes and no acute cardiopulmonary process. Prominent periilear lymph nodes, I meant to say.
Hopefully not permanent. I mean, there's some lymph nodes that exist there, but the enlargement maybe not permanent. So Margaret, why don't you assign me what you want me to talk about first, and then you can sort of gather your thoughts on whatever you want to talk about and sort of chime in second. How does that sound?
Sure. I think one of the things that we probably should address is his pancytopenia, if you could address that. And then
Yeah.
I guess, does the chest x-ray with the perihilar lymph nodes help you any, or is it still non-specific given that he has HIV? And then I guess I can talk about kind of like the infections and CD4 count afterwards.
Brilliant. Yeah, because I think the CD4 count of less than 50, it's like, we're all now basically just name one. But Margaret, you can help us like remind us which of those ones we have to name. Yeah, so the pancytopenia. So what does that do for us? Well, a lot of the conditions that we've been talking about to this point that might present with a generalized lymphadenopathy, which I would say we've now confirmed with both the palpable cervical lymphadenopathy and then the lymph nodes known in the perihilar region. So the types of conditions that present with generalized lymphadenopathy, hepatomegaly, and splenomegaly often also include pancytopenia, which this patient has. So what are those conditions? Well, they include things like, let me just actually take away the hepatomegaly again. This could be a good case for a viral syndrome like EBV, CMV, toxo, acute HIV, right? Those conditions can present with diffuse lymphadenopathy, pancytopenia, and rash. But again, we have the liver involvement, and I would say, not confirmed, but boy, have we increased the probability of infiltration of the liver with that alkaline phosphatase. Now, could this be bony alkaline phosphatase? Sure, but we've got no specter of bone involvement at this point, so I think it's very reasonable to assume for now that alkaline phosphatase is telling us the liver is infiltrated. We know that the spleen is infiltrated, probably by lymphoid cells, probably with lymphocytes, unless this turns out to be a malignancy. And the lymph nodes are also probably infiltrated by lymphoid cells. So, of the things that we've talked about so far, conditions like HLH can present in this fashion with diffuse lymphadenopathy or generalized lymphadenopathy, hepatosplenomegaly, and pancytopenia. Castleman, I believe, can also present with pancytopenia, though I'd have to confirm that to be confident. And then if we just take a step back for a moment and think about the other immune cells that can infiltrate tissues and wonder, could they present in this fashion, I think it'd be valuable. So again, neutrophils invade tissues all the time, but that's usually in the setting of an acute infection and doesn't present in this manner. The lymphoid cells, right, lymphocytes in particular, are the ones that I'm assuming are the kind that we're seeing infiltrate. Macrophages are possible here because they undoubtedly can infiltrate the liver and the spleen and form granulomas. And you can certainly see immune hyperplasia in the lymph nodes in the conditions we've talked about, although I'm not as certain that that's related to the macrophages themselves. Certainly tissue level macrophages like histiocytes, like Langerhans syndrome are other cells that can infiltrate. And then the last two to remember are eosinophils and mast cells. And the key thing about those two conditions is they are often, those conditions often lead to profound illness when you see infiltration. And I've been confused oftentimes and missed. I think Justin Peterson presented a case to me of diffuse infiltration of mast cells, but those patients almost always have symptoms suggestive of a mastocytosis. So I don't think we're dealing with that here. And we're not presented with something suggesting eosinophilic infiltration like a peripheral eosinophilia. So I think we're really probably dealing with either lymphocyte infiltration of these sites or macrophage infiltration of these sites in the setting of granuloma. So Margaret, why don't you maybe fill in some of the gaps here and maybe offer either comments on the LFTs or really anything you'd like.
Yeah, sure. I guess one of the things that I found is that the CD4 count being 7 and then going through like thinking about what organisms and what infections place this person at risk. I guess this is like ignoring the malignancy portion, which is also part of the differential given his rash, lymphadenopathy, and recent weight loss. Given his CD4 count being like less than 500, I think TB is on the differential with the weight loss, but I think without any like pulmonary findings, it's probably much rarer. And then less than 200, he puts him at risk for pneumocystis, cryptosporidia like Candida, fungal infections as well. And being from the Midwest puts him at risk for both histoplasma and blastomycosis. I think for blastomyces, I only am familiar with presentations with pulmonary symptoms, while in disseminated histoplasmosis, I think you can have like liver and skin findings as well. And then for less than 100, we can think of things like toxo, and then like the esophagitis, and then less than 50, we think of more viral things like the CMV. It could also be cryptococcal, MAC, and primary CNS lymphoma. But out of all of those, besides the weight loss, not all of them have like liver involvement, besides what I can think of as like the CMV and the histoplasmosis, mostly from all those susceptible organisms. Also, I think what's remarkable is that despite his hepatosplenomegaly, his elevations in ALT and AST are fairly modest, and so is his T-bili.
And that's actually pretty typical for infiltrative liver diseases to see an isolated elevation in the alkaline phosphatase. You sometimes can see hepatocellular injury, but this is why that crowding out, right, leaves the hepatocytes generally spared is not clear to me, even with sometimes massive infiltration. But that's often, I would say this comment is pretty typical.
Fascinating. Wow, that's yeah, I just want to just applaud you guys. That's just been such amazing teaching. And Tony, I really appreciated kind of you walking through in a structured way the different types of immune cells that can cause infiltration and how to make progress through that. One question I had is, both of you talked about, the signs of marrow infiltration. You mentioned some malignant causes, some non-malignant causes, some infections. At this point, how would you make progress in this case? What would be your next steps?
Margaret, what would you do next? What do you think?
I guess one of the things that you could test is for like antigens of different fungal infections. We could also go after the lymph node and see if a biopsy is possible. And then I don't think a biopsy of the skin would really give us any findings. So that's what I would do next. Another thing is with the hepatosplenomegaly, we talked about cross-sectional imaging, whether that be a right upper quadrant ultrasound or a CT scan as well.
Yeah, I agree with that, and I'll just highlight some of the great things that Margaret said. So those skin biopsy, if we were to pursue it, is I think less likely to be informative unless we're dealing with, like I say, a B-cell lymphoma with infiltration of the skin. That would be that's an uncommon presentation. I think we'd in some ways get lucky by finding it in the skin. Unlucky for the patient, undoubtedly. So the beautiful thing about the lymph nodes is that they're accessible, right? And so really, this is a guy who, in my hospital, we can easily get PET exam, or you could just do cross-sectional imaging and try to find a lymph node, maybe other than the cervical lymph nodes, where you could do an excisional biopsy. Because I noticed multiple people in the chat have said not just a fine needle aspiration, but an excisional is really, I think, going to be important here, because even though non-malignant, non-lymphoma diagnoses have been considered, I think lymphoma remains absolutely on the differential diagnosis. And so ensuring that we have the architecture of the lymph node when we do this biopsy is going to be really, really important. And then I totally agree with Margaret. I think you're right on target, thinking about what might be driving this as maybe in the background, whatever the ultimate syndrome is. And remembering that things like histoplasmosis, for example, can be a driver of conditions like HLH. And so, you can have idiopathic HLH, but you also want to think if that if that's the kind of diagnosis that we ultimately find, what is the driver? And so sending urinary tests for histo, I think would be valuable here. There's a lot of crosstalk with the urinary antigens for some of these endemic mycoses. So one will be positive, one test will be positive in multiple conditions, but just talking to your lab and making sure you get the appropriate one here is going to be really important. Because that's, we haven't seen evidence of calcifications or lung findings suggesting old histo, but I think that is also on the differential diagnosis. So yeah, Kushal's reminding us that histo and blasto for the antigen tests, that you'll often see a positive in either of those conditions.
I think I'm going to be honest, and during our admitting shifts, it's typically a resident and 2 interns, and I probably would be ordering a lot of serologic, like parasite smears, just to rule out for any like tick-borne illness, and then getting like complete STD testing on this patient as well. I think it's sad that this patient hasn't gotten antiretroviral treatment despite being diagnosed a week ago. I think typically we want to start someone on heart as soon as possible for most patients.
Yeah, and I noticed both in the teaching points, but in the chat, syphilis has been raised as a diagnosis, and I think that's really important to consider in a patient who has got, again, generalized lymphadenopathy and rash. What I would say is atypical is the tempo of disease here. I would say 3 weeks of such severe symptoms leading to 30-pound weight loss would be outside what I've usually seen for secondary syphilis. Again, can it present in this fashion? Possibly, but not usual. That's not to undermine Margaret's important point about getting some additional SDI testing.
Great. Okay. And actually, one last question in the chat. Suldan mentioned, does the hyponatremia in this case deserve attention? What do you all think about that?
Margaret, hyponatremia? I mean, we could talk about it for another 45 minutes, undoubtedly.
I think hyponatremia could be involved. This is one of those things where I don't think it's severe enough that I would pay too much attention to it unless it would continue to downtrend. With lots of infections, there's possibly like an SIADH component, but without like urinosms and seromosms and urine sodium, I would be hard pressed. I also, with his cachexia, don't know how he's been eating, if that could also be a component of it as well.
Yeah, I agree. It's a great question. Yeah.
Awesome. Vale, give us more information.
Okay, great. So he actually came with some labs that were performed at the time of his HIV diagnosis. So he had an IgG for hepatitis A that was positive and IgM negative. Hepatitis B surface antigen, core antibody, and surface antibody were all negative. Hepatitis C antibody and RNA were negative. Syphilis antibody was negative. Toxoplasma IgG was also negative. And quantiferon gold was indeterminate. So he also had, there's this test, I don't remember what it's called, but it's a PCR for the urine for TB, I believe, and it was negative. And some additional labs that were done at this time of admission, his fibrinogen was 77, INR 1.5, LDH was 4,836, and his ferritin was 33,000. Yeah, that's the information that I have for you. There's only one more aliquot after this.
Great. So these are some abnormal labs, and I think maybe what I'll do is I'll start by just highlighting how abnormal they are for those learners in the room who maybe just haven't seen labs like this that often. And then I'll make one comment about the ferritin, and then I'll let Margaret sort of fill in. So a fibrinogen that's low, and Ellie, for the lab that you work at, this fibrinogen is low. Is that right?
Yes.
Okay, so this is low. It's not the lowest I've seen, but certainly in the setting of this plus an INR that's elevated and a patient has thrombocytopenia, you have to be concerned about DIC. But the LDH, like wabam, okay, so that is really, really high. So I see LDH is this high in thrombotic microangiopathies. And a few other conditions, but I'll just sort of say again, I want to let Margaret have first pass on this. This is really high, over 4,000. And the ferritin over 30,000 is really high. But I want to remind everybody that in multiple cohorts of patients with the ferritins over 20,000, the most common cause consistently across these cohorts is hepatocellular injury and not HLH. Okay, so this maybe helps our case for HLH, but just remember that the most common cause of a ferritin in this range is going to be hepatocellular injury. We can talk about the mechanism of that, maybe later, if we have time. Margaret, man, these are some juicy labs for you and I, the internal medicine folks. What are we going to do with this?
So what's kind of great is that these labs directly coincide with the H score for HLH. And what I learned as an intern last time is if I'm ever thinking about calculating an H score, I should probably get a hemonc consult. But yeah, I think the fibrinogen being so low is very fascinating. I also thought DIC also being part of it. I don't typically see low fibrinogens unless I'm thinking DIC, or if someone has like plasma pheresis and has lost fibrinogen that way, or if they have like a lot of abnormal bleeding or clotting. And then I think HLH is probably in the differential as well. And then the elevated ferritins being so high, and I think it's a good point that you mentioned that like hepatocellular injury, but in this patient, I feel like his LFTs don't represent a hepatocellular picture. So that makes me think less likely that, especially with the modest INR increase, that all coincides with your differential, that this is an infiltrative process. And then I guess, let's see, for the other serologies that they have with hepatitis and syphilis and TB, I think those are all really important to get as well. But they steer us farther away from those sort of like viral, I guess, and TB and syphilitic infections as well. That's kind of what I have from here. Other things that we probably want to get as well as for the H score, besides that, is getting triglyceride levels. I think that's one of the things that we don't have, and then bone marrow features as well.
I'll just make a couple other comments about the LDH and the ferritin. So I mentioned that the times that I see an LDH in this range include thrombotic microangiopathies. And the thing to remember there, it's not solely the hemolysis that is leading to it. It's the microvascular injury, the microvascular ischemia from all those clots. That's a major contributor to the elevated LVH and the thrombotic microangiopathies. And so similarly, a really bad renal infarct because of the degree of ischemia, it can lead to an LDH in this range. And then, we're not talking like, high-grade lymphomas like diffuse large B-cell lymphoma. Those will cause in the hundreds. I think for something like this, we're talking like a Burkitt lymphoma, like the crazy ones. Where it's just like the doubling time in the size of the lymph nodes is just like extremely small or extremely short. So the differential is not particularly high for that. But for the ferritin, again, hepatocellular injury is going to be number one. Many infections, including tuberculosis and endemic mycoses, can lead to ferritins in this range. And then certainly the conditions that we classically think about with the ferritin include HLH, stool disease, and hemochromatosis. Because I think we probably have time, I'll just offer briefly that the mechanism by which hepatocellular injury leads to a massively elevated ferritin is that if there's ever anything related to iron, right? If you're on rounds and your attending is like blah 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 iron, just say hepcidin. That's just going to be the answer. Just whatever the question is. It can be like about, and just say hepcidin. Even if you're wrong, you'll sound erudite. And what happens here is that because the liver makes hepcidin, if you have hepatocellular injury, the ability for that liver to make hepcidin decreases. And so without hepcidin doing what it typically does, which is to decrease iron absorption, that's like the whole goal of it, is like, let me not absorb iron. When you turn that off, you get massive absorption of iron. And that is manifest by increases in the ferritin, which are, again, the main way that we store our iron. So be careful I've seen many cases where people try to diagnose hemochromatosis in a patient with alcoholic hepatitis because they have a ferritin of 30,000 and they have acute liver injury, and they'll be heterozygous for hemochromatosis. No, that patient almost certainly just has hepatocellular injury. That is not hemochromatosis. So I like the idea of getting some of Margaret's additional tests here, and I am interested in what the bone marrow shows. I'm not sure, Valley, if the team decided to pursue bone marrow, but I'll be honest, we gotta get tissue someplace, and so I suspect the next and final aliquot's going to talk about tissue. We're either going to be diagnosed as a lymphoma or a syndrome associated with immune hyperactivity.
Okay, so yeah, the next one is gonna be tissue, I guess, you could call it, but it's gonna be the final aliquot. So I don't know if you want to put kind of your final possibility out there before I say what the final diagnosis is.
Margaret, what do you think?
I think my top differential would be like histoplasma cyst-associated HLH, and then my second diagnosis would be some sort of lymphoma. I don't know.
I can't top Margaret's comment. That's great.
Perfect. So you were absolutely right. So we got actually a peripheral blood smear that showed intracellular encapsulated yeast within WBCs. And then the blood cultures grew at 48 hours were negative, but then at 14 days were positive for histoplasma capsulatum. And just to wrap my contribution to this amazing discussion, some teaching points from the app. So, well, the case resolution, the patient received liposomal amphotericin B for 2 weeks before transitioning to oral itraconazole. And he also received a short steroid course for an HLH-like hyperinflammatory state, and also was started an ART. He continued in itraconazole for the following year, at which time his CD4 count had climbed to greater than 200, which is the indication for patients that have AIDS to continue the treatment with itraconazole for at least 12 months or until the CD4 count reaches 150. And then, so he was thought to have acquired HIV many years prior. Some teaching points about histoplasma and the presentation of disseminated histoplasmosis occurs when the CD4 drops to less than 150, can present with fever, diarrhea, rash, hepatosplenomegaly, infiltrative liver injury, such as that explains the high outpost, pancytopenia, and signs of excess macrophage activation that can explain the high ferritin, high LDH, and low fibrinogen. And some differential diagnoses include MAC, tuberculosis, coccidomycosis, blastomycosis, lymphoma, mononucleosis, and primary HIV infection. So yeah, thank you so much for this great discussion. It was amazing.
If I could reflect on one thing, and then Maddie, you probably have some questions. If we go back to the initial labs with that alkaline phosphatase, I bet you that HLH does not have part of its syndromic infiltration and elevation in the alkaline phosphatase. And so someone please tell me if I'm wrong. But I don't remember like seeing that. I know you get hepatomegaly, but I don't know that I've seen an alkaline phosphatase as part of that. And the reason I bring this up is if let's say that's confirmed, it is a great reminder that it required explanation. And what absolutely can cause an elevated alkaline phosphatase via infiltration, as I mentioned, is histoplasmosis. And so you really wonder if that was an early clue, right? That yes, there was a lot of stuff pointing to a hyperactivation of the immune system, in this case, probably some form of HLH, but it doesn't explain everything. And so you really, in a tidy way, you'd really like to explain everything. It's not always possible, but that's what you should be shooting for. Maddie, what questions do you have for us?
Yeah, I think the first thing I need to say is that I'm just blown away by the teaching, both Tony, from you and Margaret. I think you did such a beautiful way of approaching this in such a structured way, how your differential would be different if it was just splenomegaly versus hepatosplenomegaly, but then also being very authentic to the reasoning and where the gaps in your knowledge were. So I really am just very appreciative of how you modeled that for all of us. And for the sake of time, I actually wanted to turn it back over to you and hear any reflections you have about what it was like to discuss, and any reflection on this case beyond, Tony, what you just shared.
Margaret?
Yeah, I think what I think was really cool at the end is figuring out how they got the diagnosis via the smear, and how slow the blood cultures are. I feel like personally, I haven't had much success with mycolytic blood cultures. And I think waiting 14 days in a patient is probably not the best way. I think valuing other accesses besides just like the lymph node biopsies, that was something that was pretty eye-opening to me. But otherwise, this case is like really fascinating. I think it started off like super broad and like fever and rash in an immunosuppressed patient, and then slowly with each aliquot, especially with the hepatosplenomegaly, like, and then the labs narrowing down. That was pretty cool.
Yeah, and one thing I'll reflect on is I wonder also how the tempo of illness here was a clue, right? So I think the alkaline phosphatase could have been a clue that even if we have immune hyperactivation, that may not be all we have. But fever times 3 weeks, so bad, and a disease process that's so bad that you've lost 30 pounds, I think suggests a really inflammatory case, right? So fever equals inflammation. I think we've all learned that. But fever equals inflammation, 30 pounds of weight loss in 3 weeks equals massive inflammation. And probably of the conditions that are most highly inflammatory, this is one of them. And so I wonder if, thinking back, if we could have said in the first aliquot, here, a problem representation is a 37-year-old gentleman with new diagnosis of HIV presenting with a extreme inflammatory condition, and whether or not that framing might have helped us think even from the beginning.
Yeah, I think that's a really fascinating point about how the time course could have been a clue into how extreme of an inflammatory state this is. That's a great point. Okay, Sammy, well, first I want to thank Vade for presenting this case so beautifully. There was so much data, and I loved kind of the aliquots you broke it up into. And we'll pass the mic to Sammy for all of the amazing teaching points.
Wow, that was just an amazing case and discussion, Valeria. Thank you so much. And Tony and Margaret, I think we all learned so much from the discussion and your clinical reasoning. And I'm just gonna summarize the teaching points. So we had fever, which made us think about IMATE, where we should always prioritize an infection. And it's important to remember that HIV broadens the differential diagnosis. It doesn't like shift it, it broadens. So people with HIV are more prone to common infections, but can of course also develop rarer diseases. Then we had this finding of the rash, which made us think about infections, and mostly mononucleosis syndromes, measles, tick-borne related, syphilis, toxic shock syndromes, also infective endocarditis and endemic fungi, also autoimmune causes, mostly collagen vascular diseases, vasculitis, adult onset Still's disease, malignancies, lymphomas, and leukemias, but also very importantly, drug reactions, for example, drug-induced hypersensitivity syndrome, Stevens-Johnson syndrome, and HAP, which are all more common in patients with HIV, which Max astonishingly mentioned in the chat. Then we had this finding of the macular rash, which is mostly caused by mononucleosis syndromes, syphilis, and also drug reactions. And you can always ask for itchiness, which would prioritize a drug reaction if there is exposure. Then we had this finding of weight loss in a patient with HIV, which made us think about opportunistic infections, new onset malignancy, or directly HIV related, which is called wasting syndrome and is multifactorial. Then we had a lot of discussion about multicentric Castleman's disease, which has three etiologies. Either it's HHV associated in HIV, or plasma cell dyscrasia associated, or idiopathic, and it mostly presents with B symptoms, diffuse lymphadenopathy, anosarca, hepatosplenomegaly, and skin findings, with a very typical finding being cherry hemangiomas popping up acutely on the body. Then we had this interesting finding of pancytopenia, which we can think about as a peripheral destruction, splenic sequestration, or a bone marrow problem. Then we had isolated alkaline phosphatase elevation, which was very prominent in this case. And the clue that I learned from Ravi is that we should always check for bony causes, and if it's coming from the bone, it's usually painful. For example, Paget's disease or osteomalacia. But if the liver is the cause, it's usually painless, and it's mostly for infiltration of the pericortical fields, which prioritizes a granulomatous versus a liquid granulomatous disease versus a liquid cancer. And the nice pearl is also that syphilis and giant cell arteritis can also cause isolated AP elevations. Then we talked about how important it is to identify and acknowledge your knowledge gaps in medicine, because that gives you an opportunity to learn, improve your knowledge, and also express humbleness, and therefore encourage others to do the same, which is very important and one of our main missions here. Whenever we have unclear lymphadenopathy, we should pursue serologic testing first, but also consider early on getting an excisional lymph node biopsy over fine needle aspiration, because a fine needle aspiration just has a lower yield for lymphoproliferative disease detection. It's also important to remember that STDs travel together. When we check for one, we should always also check for the other. HIV, chlamydia, gonorrhea, and syphilis. There are also rarer ones like Plasma and Trichomonas. Then we had this interesting finding of very elevated LDH, which can happen in hemolysis, white blood cell turnover, spontaneous in leukemias, but also after treatment as complications of tumor lysis syndrome, but also in organ necrosis, for example, the lung, liver, kidney, spleen, muscle. But very interestingly, what Tony taught us in TMAs for direct injury of the vessels in TMAs. When you think of hyperferritinemia, we should from today on prioritize hepatocellular injury, which is mediated by hepcidin deficiency, which increases iron absorption through the GI tract and release from the reticular endothelial system, or can also happen in massive inflammation, and only rarely HLH is the cause. And when we think about HLH, it's diagnosed with 5 out of 8 criteria. You can calculate an H score that gives you a probability of it, and we should think of it as a symptom, not a disease. Mostly it's caused by lymphomas, but can also be caused by SLE, adult onset Still's disease, HIV, endemic mycosis, CAR T cell therapy, and can also be congenital. So thank you all so much for joining today, and thank you for this amazing hour. And I think we all learned so much and had a great time.
Oof, those were incredible teaching points. You summarized all of that so beautifully. So thank you, Sammy. And
Great job,
Tony
Sammy.
and Margaret, thank you so much for being here and for making this such a great hour of learning.
Our pleasure.
Awesome. Bye, everyone.